The most important part of communication, particularly therapeutic communication, is the interaction between the nurse and the client. Focuses on the client's physical and emotional needs. So we want to establish those therapeutic relationships early on with our clients. We want to find out what is important to them. How much do they even know about the disease process? How much do they know about the interventions that we're trying to implement? These interactions require the use of effective communication strategies in order to provide that support to that client. Key factors to active listening, purpose, the health related reason for gathering the data of giving this information. What is the reason that we are getting this information? Discipline attention. Do not assume accuracy of information without checking it out first. We do want to clarify what we think the client understands and also verify the information that we're getting, that we're actually receiving. A common mistake in listening is to listen to words, but not really hearing the words. We want to make sure that we're comprehending and understanding. Nurses are the center hub, for we function as a collaborative member of the healthcare team for patient care. Nurses should provide safe care. So we should be thinking about medication administration rights, question orders that are unusual, make rounds, report those findings, and etc. Client safety is priority. We want to use the chain of command to assist if there's no response from the healthcare provider. We serve as that advocate for that client. We do want to assess our client's understanding of what they know, what are their goals, what are their plans. And this will assist with that, establishing that therapeutic relationship. And so these active listening techniques will assist us into verifying, ensuring that we, as the receiver of the information, that we are receiving the correct information with a correct meaning. So reinstating, this is repeating what the patient said in a slightly different way. Clarifying and asking questions in response to a patient's statement to be sure that we understand. Reflecting, putting into words the information that we receive from the patient at an effective communication level. Expressing in our own words what we think the patient means. This is paraphrasing. Minimum encouraging, using sounds or words to encourage the patient to continue. Remaining silent. Summarizing, stating the main data that we have gathered, and then validating allows the patient to correct information when summarized. We, as the PN, we reinforce the teaching. We want to communicate effectively. This promotes patient safety. Even when we're handing off, we want to make sure that we are giving the correct information and also receiving that correct information. As an advocate, we clarify orders if needed. Does this order have all the components? We want to ensure that the patient receives the best care and the adequate treatment. And remember, the patient has the right to refuse. So while we are engaging in conversation with that client, we want to make sure that the client understands the information so that they can make an informed decision. And we want to support them in the event that they decide to refuse. Ineffective communication is the primary cause of bad outcomes, signal events, where there's hurt, harm to the client's limb, life, or eyesight. Okay, so positive communication techniques, developing trust through openness, honesty, integrity, and dependability. Being an attentive listener, showing empathy, and developing trust. Increased communication among the team. It improves team satisfaction and is an advantage to the team. Using iMessages, establishing that contact, keeping promises, using that open communication, being aware of our body language, making sure that our body language is not negative. Okay. We want to ask ourselves, is the communication effective? Was the information received in a manner that it was intended? Is what actually communicated what was actually being communicated? Okay. And this in itself will increase the patient satisfaction. The client will feel that you have their best interest at heart. And because you're taking into the things, their information that they're sharing, we're considering that. Generalized answers, these are negative communication examples, giving advice. Even though the clients, the patients, you will be that trusted individual because you're the nurse. And they will ask you many times, well, what would you do? But because we are not the patient, we want to make sure that they have enough information so they can make an informed decision. And we just let them know that we will support them in whatever decisions they make. But please don't give advice because that is considered negative. Okay. So SBAR, what is it? Situation, background, assessment, and recommendation. This is a structured way of communicating with others on the healthcare team, whether or not we are talking to that healthcare provider or we are giving report and we're doing a change of shift. If a patient is being discharged, we want to ensure that we are giving that patient being transferred to another floor, another facility, or even home. We want to make sure that all of the information is there so that that client's care is not held up. So that client continues to receive the care that they need. We want to make sure that the care, the information that we are given is being given in the first language in terms that the person can understand, and then make sure that it is appropriate. When what is the information? Is it being adapted to the patient that it actually involves? When we are coordinating using SBAR, it helps us to coordinate that patient's care, to communicate that care effectively. And it decreases the chance of hospital readmissions, things being forgotten. Now let's look at it a little bit more in depth here. So the situation, this is when we're talking to the healthcare provider. What is the reason that we're calling? We want to include our name, the unit, the patient's name, and the problem. Background, admitting diagnosis, date of admission, current status information. That's their vital signs. We want to make sure we have current vital signs with medications, their allergies, if they have IV fluids, and their code status. Assessment, what do you think is going on based on the data findings? We want to collaborate with that RN. Is this life-threatening or not? And then recommendation, goals of care, what needs to be done, including a consult, medication order. Does this person needs to be transferred to another floor, to another facility? When we were doing change of shift, we still use SBAR. Remember, SBAR allows us to communicate effectively, helps us to coordinate that care, continue the coordination of care for that client, making sure that everything is appropriate, the information is specifically about that patient. So when we're doing change of shift, the situation is, we're going home and the next nurse is coming, but we still want to give that admission date, the chief complaint, and their diagnosis. We want to look at that background. What's their medical history? Where's their code status? What's the latest lab results? Do they have any pending lab results? An assessment includes those vital signs, that pain assessment. What were the diagnostic studies? Do they have a chest x-ray? Do they have an EKG? And then recommendations. What are those goals of care? What needs to be done? Education and discharge needs. Okay. Conflict resolution. Accept conflict could be a part of life. Temper your own attitude and behaviors. Be aware of your initial reaction and take a deep breath. You want to take time to think critically before reacting. Effective communication can resolve conflict resolution. We want to listen, and we want to make sure that we're discussing things privately. We don't want to violate HIPAA. Treat conflict as an opportunity to voice your own opinion and listen to others, listen to the other side of the story. You want to choose your approach. A win-lose approach will only escalate the intensity of the feelings being involved. Listen and learn. Listening and discussing privately can help assist with resolving conflicts. Because if you're discussing it privately, the attention of either party is not focused elsewhere. Okay, let's look at the DISC script. So this model is used to resolve conflict. We want to describe a specific situation or behavior to provide concrete data. Not what is, not assumptions, but provide that concrete data. We want to express how the situation makes the person feel. What are the concerns? We want to suggest other alternatives and seek agreement. And then consequences should be stated in terms of the impact of the established team goals. We want to strive for that consensus. Okay. We might have to, if we are, remember we're advocating and we're supporting our clients' autonomy. We respect the patient's right to make their own decisions and choices. We must remain respectful and courteous, ensure that the patient has enough information to make an informed decision. So there are times when we might have to question an order. We might have to ask our nurse manager to assist us in getting resolution. But sometimes, you'll have all the components of an order there, but then you may notice that it could be an unusually high dose or an unusual dose that's given. So, but our client safety is a priority. So we would want to use a chain of command to assist us if there's no response from the healthcare provider. Because remember, we serve as those advocates for those patients. Okay. We have non-assertive, which is passive, also aggressive and assertive. Passive is a barrier. Well, actually, non-assertive and aggressive both are barriers to communication. Passive passes the task on. It does not complete what needs to be done. And this is really a form of being dishonest. Aggressive is again a barrier to communication, is disrespectful. This communication belittles or makes fun of or dominates and put others down. And then these being non-assertive and aggressive, these make the patient feel unsafe. Assertive, we're using facts and not judgment. We're being honest, we're being respectful, we're maintaining professionalism, we are not belittling, we're standing up for our clients' rights without violating the rights of others. And then this being assertive and being honest makes that client feel safe. So we work on that interprofessional healthcare team. Remember, I said that, we as a nurse, we're that central component, and we're there to keep that care coordinated and to provide that individualized care for our clients. Promoting that client will have the best outcomes. There are just a few that are listed on the healthcare team here, but there are so many others. But yet everyone is essential in that client receiving their best care and having those best optimal outcomes. We do want to ensure collaborate so that care continues for that client. Primary nursing can facilitate continuity of care, resulting in shorter hospital stays. It lessens the chance of readmissions. Some facilities use care maps or different tools that are like that to prevent the client from having complications, and also readmissions. Okay. Delivery of nursing care in the acute care setting. You have that total patient care, functional nursing according to the task, team nursing, assignments according to the capabilities. And the RN is that team leader. Okay, so team nursing, the capabilities of each team member are used effectively. Functional nursing is task oriented according to that task. Primary nursing, the RN individualized client care. Remember, the RN is coming up with that nursing care plan and accept responsibility and accountability for the total client care. And then case management focuses on delivering cost-effective quality care to clients with complex needs. Providing care that is respectful and responsive to the individual client's preferences, needs, and values, and ensuring that the client values that all clinical decisions. This is very important in establishing that therapeutic relationship with that client. Finding out how much do they know about the disease process? What are their expectations? What are their preferences? What would they like to see happen? What questions do they have? Developing clinical judgment. We need to be recognizing patterns, applying concepts, thinking about what's the best response, and then be reflective of the practices. Okay, we have CUSIN, Quality and Safety Education for Nurses. The initiative anticipates that collaboration will have a major impact on positive patient outcomes and improve that quality of care. It lessens the chances of readmissions. It lessens the chances of complications if we have that effective collaboration. Differences between management and leadership. Management coordinate people, time, and supplies to achieve desired outcomes in a defined area of responsibility. Okay, leadership is the ability to empower and influence the beliefs and opinions of others or behaviors of a person or group by guiding, motivating, and inspiring them to accomplish common goals and recognizing their successes. Okay. These are different leadership styles and theories. The nurse is responsible for supervising patient care to ensure it is completely delivered in the safest manner possible. The nurse is responsible for supervising patient care to ensure it is completely delivered. The nurse should consider the knowledge and the skill set needed in order to say that that team member is competent. For example, for the unlicensed personnel, remember they can assist with bathing, measuring those blood pressures, mouth care. The nurse can administer medications, they can provide wound care. The condition of the patient needs to be assessed as well, because if we have a client that is unstable, we would not delegate that client to an unlicensed personnel, even though that is a task that they can complete. What task to be delegated? When a task is being delegated, what is the skill set? What is the experience? What are the tasks that needs to be completed in order for that patient to be effectively taken care of? We want to care We want care to be provided safely and efficiently in an organized manner. We want to make sure that we have these five rights of delegation met when we are deciding to delegate. Is this the correct task? Are these the correct circumstances? Is this client stable versus unstable? We want to ensure that we're communicating um, effectively so that the correct information is being received. So we want to make sure there's a clear explanation about the task and the outcomes and when the delegatee should report back to the RN or report back to the LPN. We want to make sure that we are supervising and evaluating. And remember, just because we delegate, it does not mean that we are relieved of those tasks. We still must oversee and ensure that those tasks have been completed. Before you delegate, the client must be assessed, data gathered on their conditions. Is client stable versus unstable? A CNA and an unlicensed personnel cannot delegate. Delegation cannot be transferred. The delegatee can refuse the delegation, but we want to find out what's going on. It could be something personal, it could be something professional, but nevertheless, we need to find out what's going on and use that nursing process. We can't get away from that nursing process, and it's there to assist us even when delegating tasks. Don't forget, we are mandated reporters. We don't have to confirm, but if there's a suspicion, we must report. We are the client's advocates. We do want to respect the patient's rights to make their own decisions, their own choices, and we want to ensure that we remain respectful and courteous, ensure that the patient has enough information to make an informed decision.